Welcome, everyone. My name is Karen Brownlee, and I am the Adult Program Coordinator at the North Suburban YMCA in Northbrook, Illinois. And in that role, I bring a lot of programs to our community, including things like brain games, and we have a social networking group. We do some social outings, or at least we used to. We now do everything online. But we have this great program called the Adult Education Series, which this year, even with COVID, we're bringing more than 75 Adult Education Series programs to the community, where I bring in adults who are experts in their field to come in and talk about their areas of expertise to educate you, the public, adults in our community, about topics that are of interest to you. So today we are very fortunate to have Betsy Montgomery, who's with North Shore University Health System. She is a pelvic floor, she's a pelvic physical therapist, pelvic floor physical or pelvic
pelvic floor physical therapist. You got it.
I did get it right. Okay, she's a pelvic floor physical therapist. She'll probably explain to you a little bit more about what that means. She did a program for us a year-ish ago, a little more than that, I think, actually, which was wonderful. Everybody loved her and said, Karen, we need to get her back again. And we did. And then COVID hit, and so we had to put it off, but we've got her again now. She's here to talk about bowel disorders. So I'm going to ask you to mute when you come on. And then if you do have a question for Betsy, you can unmute yourself and ask the question, and then mute yourself again if you would. We anticipate being here for about an hour. So thank you again. With no further ado, I will introduce Betsy. Thank you, Betsy. I'm going to turn off my camera and mute myself as well, but I'm here if anyone needs me for anything. Thanks, Betsy. Take it away.
Thank you. And thank you all for being here. And thank you for the warm introduction. So my first discussion was on kind of bowel issues and pelvic organ prolapse. And so today I'm here to talk about perhaps the uglier side of the pelvis, which is bowel disorders. And so understanding constipation and fecal incontinence, which are actually two of the more common diagnoses I treat. So I work down the street at North Shore at Glenbrook Hospital in the lovely basement there. And I am an orthopedic therapist by training, but I have further subspecialized in the pelvic floor. So I treat men and women with bowel and bladder disorders, pelvic pain. I treat pregnant women, postpartum women. And so bowel disorders are actually one of my favorite things to treat. And so I'm happy to be here talking about them today. So let's see if we can, there we go. So what I'm here to chat about today are just pelvic floor, and then the rectal and bowel anatomy, discuss a little bit more about what constipation and fecal incontinence are, discussing normal habits, the best ways for you to optimize your routine, talk about what physical therapy could do to help address some of the issues, and then talk about, when it might be appropriate to seek medical treatment. So to first go into the anatomy, so when I'm here talking to you all today about the bowel, I'm talking about the large intestine, which is also known as the colon or the large bowel. And so it is this larger segment of colon that kind of moves in a clockwise direction around your abdomen. And it actually starts on the right side of your abdomen. So if you feel the spot between your hip bone and your belly button, that's about where the small and large intestine meet, and it meets at this valve called the ileocecal valve, right? And so feces actually enter the large intestine as liquid, but as they move through, water actually gets pulled out, and that's really the largest function of the large intestine, is to absorb water back into the body, so that as fecal material reaches down towards your rectum and anus, it's actually more solid. And that solid form is what allows it to actually stretch the rectum, and that's what gives you the urge to need to go to the bathroom. And so as we talk about some of the issues that can impact the bowel, sometimes there becomes an issue if things are moving really slowly through the large intestine, too much water can leach out, or if it sits in the rectum for too long, a lot of water can leach out, and we'll talk about that a little bit later when we discuss constipation. But just so that you can kind of see, we have the ascending colon here, so that goes up the right side of the abdomen. We have the transverse colon that goes kind of around on the top underneath your ribs, and then the descending colon that comes down on the left side, and then into the sigmoid colon and rectum. So when we're talking about the bowel and bowel function, we can't leave out the pelvic floor muscles. So this picture here, looking at the pelvic floor, is, I'm just going to get the laser pointer. Here we go. So this is if you were to cut yourself in half through the waist and we're looking down into the pelvis, and you can see that there is this shape of muscles here. It's really like a bowl, and that is your pelvic floor muscles. So it's really a group of 3 muscles, but they all work together. And through the muscles, we have little openings or tubes. So in the back here, the anus passes through, the rectum and anus passes through these pelvic muscles. And then this opening in the front is where the urethra and the vagina are able to pass through these muscles. So certainly when you're trying to evacuate bowel, these muscles are going to be important in that operation. So really, the main job of these muscles is to contract to help you maintain bowel and bladder continence. They need to relax in order for you to empty out your bowel and bladder. They're also there to help support your pelvic organs. So in women, that's the bowel, the bladder, and the uterus, unless you've had a hysterectomy. And then they help stabilize the core. So technically they are a part of our core complex, which we usually think of as just the abdominal muscles, but the pelvic floor are a really important component in that structure as well. So I wanted to show a little bit of the relationship between the pelvic floor and the bowels. So this picture is taken as if you were to cut yourself down through the middle of the skull into right and a left half, right? So if you're looking in, you can see this is your pubic bone right here. Here's your bladder. This is the uterus. I'm assuming we have mostly women. If you're a man, I'm sorry, you don't have a uterus here. And then the rectum here, right? So this is the end of the line for the bowel, and this is where fecal material kind of aggregates until it's an appropriate time for you to have a bowel movement. And then down here, you can see these like little red streaks here. This is the anal sphincter. So you do have a muscle there. Stool has to pass through there. Okay, and I'll show you on the next slide, one of the pelvic floor muscles, which is kind of poorly shown in this picture, actually does make a loop around the bowel to help create the outlet into the anus. It's called the Puborectalis muscle, and that is really a big player in bowel continence, but it's also one of the biggest players in constipation. So we're going to talk about that a little bit more. And so the rectum here is supported on the bottom by the pelvic floor muscles, but it's also suspended at the top. If you can see kind of all these this purple coloring here, they're ligaments that suspend the bowel. And so we'll talk about this more as well, but sometimes if those ligaments are impacted, then the rectum can kind of drop or flatten down, so it's not in this upright shape. And that can also be one of the reasons why we get some bowel issues. So I was alluding to that puborectalis muscle just a minute ago. And so again, if you look at the picture on the top right, it's this muscle in green. So it's this quick loop, and this hole right where my laser pointer is, that's where the anus is, right? This other picture is showing the body if you were to be cut kind of in half into a right and a left side. So this is the pubic bone in the front, and you see that this puborectalis muscle comes around and slings around the rectum and kind of kinks it off like a garden hose. And that's really beneficial for us in order to maintain continence. So we may find that in women who have more of a difficult time controlling their bowel movements, that maybe sometimes that muscle could be weak or not functioning correctly. So when we do have a bowel movement, so this is at rest, this picture is at rest, but when you do go to have a bowel movement, this muscle actually has to relax such that this angle kind of increases, so it becomes closer to a straight line. It's not so kinked off, right? So you can imagine it would probably be really difficult to get stool kind of around this bend and out. And so that's helpful sometimes, but not when you have to go. So I'll talk on that a little bit more. But just so you know, this muscle, the puborectalis, is a big deal when it comes to bowel function. So before I talk about some of the bowel issues and constipation and fecal incontinence, I wanted to touch on what's normal for the bowel habit. And this is something that I always educate my patients on, usually their first or second visit when they're coming in, really for anything pelvic related, pain, urinary issues. A lot of the time the bowel can kind of lie in the shadows and contribute to their problems. But as far as normal bowel habits, there's kind of a wide variety of what's normal and acceptable. So really that could be going once every 3 days to 3 times per day, right? So that's kind of a big spectrum there. And really what I care about more as a pelvic floor therapist, and probably the gastroenterologists and colorectal specialists out there care more about, is actually the consistency of your stool versus the frequency of a bowel movement. So we want your stool to be soft and formed, right? We don't want the hard rabbit balls or really hard lumpy stool. That's going to be a lot harder to get out. And we also don't want diarrhea. We don't want really loose stool, right? That's often more difficult to control. So this is the Bristol stool chart developed by Dr. Bristol. And so we shoot for usually a Bristol type 3 or a Bristol type 4 as far as, what we want to see. And so even if you're having a bowel movement once or twice a week, as long as it's this consistency, we're not as concerned, right? We definitely advise against straining to empty your bowels. And that's really not great for the pelvic floor muscles. All that pressure down can cause those muscles to stretch. It can contribute to pelvic organ prolapse. And so definitely things that we don't want to deal with. I know some folks who tend to be more constipated tend to spend a lot of time on the toilet. We really don't advise longer than 10 minutes, just because the longer you're sitting on there, the more gravity on the pelvic floor muscles, again, the more likely they are to overstretch, and the more pressure that's going to put on the ligaments that are helping to suspend your the bladder, the uterus, the bowel, right? And you'll hear me talk a lot about habits as we go through the rest of the presentation. So what I mean by that is just your bowel really likes a habit. So you're eating the same kind of foods at the same time of day, you're getting enough fluid and fiber intake, you're exercising. It's almost like your bowel likes a Groundhog Day, or you're kind of doing the same thing every single day. And that's honestly one of the biggest reasons people get constipated when they travel, is because you're out of your routine and your bowel just needs some time to get a hold of itself, right, and adjust to that. And then finally, we'll talk about defecation dynamics, but believe it or not, there is a optimal way to sit, generally with your feet propped up, to ensure that that puborectalis muscle and your pelvic floor in general are relaxing enough to get material out. Right, so thought we'd talk about constipation first. So I think constipation is probably one of the biggest underlying health problems that we don't realize. And I find that more often than not, as far as my patient population is concerned, most people are constipated and most people don't know that they are constipated. So just to give you an idea, constipation affects about 2.5 million people per year, or about 1/5 of the population. And that really is not necessarily age dependent. We see it in kids, young adults, middle-aged folks, and then into the elderly population, although it is more common in women and in elderly. It can definitely cause restricted activity. It can be really painful, be really uncomfortable. And so that will contribute to restricted activity, even bed disability a year. We Americans like to spend money on dealing with our constipation, so it's an expensive problem, right? And as I said, most people aren't aware of it, but on the other side of the coin, it's generally treatable and manageable conservatively without needing any other sort of medical intervention. So there is a specific criteria for diagnosing constipation, but generally what we can see just kind of in our own day-to-day is we're looking for hard and dry stools. And I think that's what most people identify constipation as, or that they have to strain really hard to get the stool out, or that they're going less than 3 times a week. I've had patients that are like, you know, I haven't pooped in 2 weeks, right? You definitely know there's constipation there. You could also be considered constipated if you know, are successful at passing some stool, but then you feel like you didn't get everything out, right? That still falls under the constipation umbrella. And then, you know, certainly, at least by the time that I'm seeing these patients, their constipation is severe enough to have a negative impact on their quality of life, right? So it's not something that, it's not great, and it's something that is usually treatable. So it's important to know kind of what to do to recognize that. So there's a lot of reasons why constipation happens. So if you remember that first picture when I was describing the anatomy of the colon, so sometimes the colon, there are muscles in the colon. We don't have voluntary control over them. So they're controlled similarly to the heart, right? They just kind of move automatically. And sometimes those muscles just aren't getting the signals that they need to move material through at a good pace. So we call that, sometimes it's slow colonic transit, right? The colon is just lackadaisical, taking its time to push things through. And sometimes if that happens, we see that too much water gets absorbed from the colon. And so that's what makes those stools really hard. It can cause them to break up into smaller balls. In regards to rectal stretching, sometimes if a fecal material is aggregating there, you know, maybe we put off the urge to go, right? Oh, I'm in public, I don't want to go to the bathroom, or, oh, there isn't a bathroom, I'm going to have to wait. And so sometimes holding too long, more and more stool can actually stretch the rectum to the point that the threshold that we would expect for needing to go to the bathroom actually gets lowered. So it's going to take a lot more stool to indicate that we're full, that we need to go, right? Sometimes the rectum isn't able to push stool out, and that could be any change in anatomic change in the rectum. So if you have a prolapse, that could be a contributing factor to that. If the pelvic floor muscles aren't able to relax enough, that can make it difficult to get stool out. Certainly anorectal problems like colon cancer or fissures can contribute. Those are a lot less common as it relates to kind of just the day-to-day constipation, although on a sidebar, colon and anorectal cancers are on the rise in our culture. And that's a discussion for another day, but certainly you could have like a physical obstruction, or if you have an anal fissure, which is a little like a scratch or a tear in the surface and the lining of the rectum, it can just be really painful to poop, right? You just don't want to go. A sedentary lifestyle, and medication side effects. Basically, if you don't move, your bowel's not really going to move. Laxative abuse, and then generally the bad habits that I hit home with my patients are that people just don't get enough water and they don't get enough fiber. So the recommendation for fiber for American women is about 25 to 35 grams per day. And I usually have my patients just kind of track what they're eating. And a lot of the time, you know, even if you're having huge salads and stuff, we may not even consume enough to reach that fiber goal. And certainly that everyone's different, and there are people that can't have a lot of fiber for different reasons. But I generally tend to recommend like a fiber supplement to just kind of bridge the gap. But certainly the water intake is also important. So habits are kind of key for bowel success, and that's really what we work on in physical therapy. So there's a couple different kinds of constipation. There's the functional constipation, which basically is indicative of a muscle problem, right? Those pelvic floor muscles that have to relax. Well, maybe they're contracting when they need to be relaxing. And believe me, I don't know what leads to that, what causes that problem, but that's probably the number one reason people are constipated, at least as far as my patient population goes. You know, their gut's working fine, their diet's okay. It's just when the stool gets down and it's ready to go, it can't get out because of the muscles. There's structural constipation, and that is more indicative of like a prolapse or some sort of damage to the colon. Anyone who's had any kind of radiation to that area, or who have maybe had like diverticulitis, diverticulosis, where there's actual structural changes in the large intestine, where there's more of a physical obstruction to stool. This is a little bit less common, and it's not always something that we can manage in pelvic floor therapy. But again, usually the habits, optimizing the habits can help. There's secondary constipation. This is also quite common and can be due to another disease process or a medication side effect. So I know some of the more, lots of medications are constipating, and that is the unfortunate truth. A lot of the anti-anxiety, anti-depression medications are constipating. Diabetes medications are constipating. Medications for neurologic disorders like MS and Parkinson's can be quite constipating. And then finally, there is irritable bowel syndrome, but the constipation dominant form of that. And so that is generally due to decreased nerve control of the large intestine. And so that is generally managed by medication. The neurologic function of the bowel, unfortunately, is not something that we can really impact from a physical therapy standpoint, but generally it can be conservatively managed with medication. So as I kind of was saying earlier, the symptoms of constipation, right? Straining to empty, hard stools, feeling like you didn't get everything out, a lot of abdominal bloating or pain. Some people need to use their fingers to remove stool. Some people need enemas or stool softeners or laxatives to go. And actually, one of the more interesting symptoms of constipation is actually fecal incontinence. Sometimes if you are just so full and so stopped up, you run out of space, right? Something's got to give. And so sometimes we see that stool will leak out, usually liquid stool, and it kind of seeps around the more solid stool, and you leak. And so that's a delightful presentation. And I'll be honest, most of the patients that I see who have fecal incontinence are actually constipated. It's not its own issue. The other delightful impacts constipation can have, it can affect your bladder, right? You don't have a lot of space in your pelvis, so your bladder and your uterus and your bowel are all kind of crammed in there. So if you are full of poop, that can sometimes impact how much urine your bladder can hold. So you might feel like you have to pee more often, or when you have to pee, it's really urgent. You might leak urine more often, right? There's all that pressure down on the pelvic floor muscles, just from that stool burden, that the pelvic floor muscles are then no longer able to maintain your urinary continence, right? It can contribute to pelvic pain with intercourse, pain after intercourse, and it usually again is reflective of just the burden that's the bowel is putting on the pelvic floor muscles. And then I'd say some other common symptoms are low back pain, radiation of pain into thighs, groin, buttocks, and some people can actually get really bad headaches. when they're constipated. So just a delightful myriad of symptoms there. And I did want to just mention that, you know, again, the elderly population is a lot more likely to get constipation. And a lot of that has to do with changes in their colonic motility. So again, that is controlled by nerves. So we see the decrease in nerve function with age. So you're not going to have as many nerves controlling the gut. And so that causes things to move slower. And then we see that with age, we get these collagen deposits that make it harder for that bowel to stretch and impact the motility, right? So it can't really push things through as easily. And so I always kind of compare that. This is kind of a gross general comparison, but collagen deposits can look like little pieces of beef jerky. So if you can imagine trying to stretch beef jerky, it's a little bit difficult, right? In regards to the anal sphincter itself, we see decreases in muscle mass with aging. And so you may not get as good of a squeeze in the anal sphincter. And you may not see that the pelvic floor muscles are able to relax, and the rectum's not able to relax enough to induce the mechanism by which we have a bowel movement. And unfortunately, I mean, definitely some of these things we can't really help, right? But keeping moving, maintaining strength is probably the best thing we can do as far as promoting optimal bowel habits with age. So when it comes to the do's and don'ts of constipation, we encourage breathing, just nice belly breathing to relax your pelvic muscles. There's this idea of a squatty potty, and I have a picture, I think maybe on the next slide. Basically, if you can sit on the toilet in such a way that you get your knees higher than your hips, that tends to help those pelvic floor muscles relax. Eating your fiber, drinking enough water. I have a picture of a bowel massage, and we use that to kind of stimulate the gut. It's not used to push stool through. And then certainly sitting on the toilet. Some people like to hover, and that's definitely going to make it difficult for your body to do what it needs to do, right? And we don't advise straining to empty. We don't advise ignoring your urge to go, right? You should go to the bathroom when you feel like you have to go. And certainly there are circumstances where that's not an option, but as a general rule, you should go. Try not to spend longer than 10 minutes on the toilet, and then try to avoid using your finger to remove stool. And this is actually quite common, right? There's people who manually remove stool. It's actually a lot more people do it than you would think. And that's when, you know, it's gotten to a point where, you know, it's definitely impacting the quality of life. So this is the picture of the optimal defecation dynamic. So this red line here, this is one that puborectalis pelvic floor muscle, right? So when you're sitting just regularly and you have a 90-degree bend at your hips, that muscle is kind of kinking off the rectum, right? So you see you have more of an acute angle. When you get your knees above your hips, that muscle is able to relax such that your rectum becomes more of a 180-degree angle, right? It's certainly going to be easier to get stool out that way. And then certainly you have to create some force to get the stool out. And we usually recommend trying to exhale as you're bearing down, right? Don't let your throat close. Try to exhale to evacuate your bowels. So I know a lot of pelvic floor therapists we're all deeply bitter and upset that we didn't create the squatty potty. And you really don't need anything special that's like a brand name special stool. Even like 2 Kleenex boxes is sufficient, you know, for lifting your knees up. And then I have the diaphragmatic breathing here. So that's like a belly breathing to help those muscles kind of expand and recoil. On the left here, this is an image of bowel massage. So you would kind of you press gently into your abdomen and make small little circles, working your way up around and down in a clockwise direction, and you're not pushing real deep, but sometimes just pressing over the skin can stimulate some of that bowel motility. All right, so moving into fecal incontinence. So certainly less of an issue in our society than constipation. It can impact 2 to 24%. It's a wide range. We certainly see this more commonly in frail elderly and postpartum women. And for that reason, generally having had babies, any lacerations or tearing, women become a lot more likely to develop fecal incontinence than men do. I don't have children yet, but I have heard from many of my friends that you hang out in diapers with your baby after your baby's born, and a lot of the time it has to do with bowel control. So fecal incontinence is defined as any involuntary loss of stool with or without urge or awareness that's happening for greater than 3 months. Right. So it's usually, sometimes we think of it as like looser stool, and certainly it's harder for our body to control looser stool. You can have incontinent episodes of more formed stool. So it's not specific to diarrhea, although that's what I have circled here. And I think it's important I want to highlight that, people think, okay, fecal incontinence is if I just entirely poop my pants, right? All of my poop has come out. But really that's not true. Fecal incontinence can include, maybe some difficulty controlling gas or liquid stool. There's anal incontinence, which kind of falls under the same umbrella, but loss of any mucus. I would say more people who have fecal incontinence are ones that have to wipe, and they might use a whole roll of toilet paper after they've had a bowel movement. Or if you wiped and you feel like you're clean, and then later on you go to the bathroom and find like a smear of stool in your underwear, that is technically fecal incontinence. And I'd say that's a lot more common than entire loss of bowel contents, but not something that we always recognize as being a problem, right? But it can certainly be embarrassing. So fecal incontinence, again, is usually the result of bad habits, at least in American culture. As I find it, it's often an indicator that there's some underlying constipation or incomplete emptying. Certainly, your anal sphincter muscle may not be able to work correctly. The anal sphincter muscle is next to the pelvic floor muscles, but it's its own separate muscle. If you've had any prolapse or changes in bowel or rectal anatomy, muscle weakness, any neurologic disorder, such as Parkinson's, mobility deficits, so some people who just get the urge and they can't get to the bathroom in time, bad diet, eating things that are more irritating to the gut. Certainly those patients who have inflammatory bowel conditions, so irritable bowel, Crohn's, ulcerative colitis, pregnancy, and generally vaginal delivery can all contribute to fecal incontinence. So there's 3 kinds of fecal incontinence. So there's passive. So that's generally it happens and you're not even aware that it's happened, right? Or you get the urge to go and you just can't control it and you're trying to hold it and it just comes out. And then there's fecal seepage, which can be passive. So that's, or you can be aware of it, which is just leakage of stool material, either into your underwear or excessive wiping after a bowel movement, or stool that comes out maybe like during exercising or running. So fecal incontinence is usually a little bit more obvious than constipation as far as its existence, right? So again, you may have a lot of issues with gas, controlling stool mucus, a lot of urgency, seepage. You may know that you're constipated. You can have a lot of abdominal pain. And much like with constipation, some people with fecal incontinence can have very similar urinary, sexual, and musculoskeletal issues. So I will say in general, when I have a patient who has either constipation or fecal incontinence, that's rarely an isolated problem. There's usually something else going on, right? They have pain using a tampon or having intercourse, or they're leaking urine, or they have to pee all the time. So generally, these other symptoms are associated. Certainly, as we age, we recognize that there are cognitive and mobility impairments. The older folks may be holding on to stool more, and that may be more the problem. They get the urge to go, but they're not able to indicate that, and they overflow, essentially. We lose pressure in our anal sphincter tone as we age. We lose sensitivity in the rectum, so we may not be getting the information that we need, telling us that the rectum is stretching and it's time to go. Certainly prolapse, and the risk for prolapse increases with weakening of pelvic floor muscles, age, and the number of vaginal deliveries, especially with episiotomies or other perineal trauma. And then certainly these issues can worsen with other health conditions like diabetes, MS, high blood pressure, etc. So again, with fecal incontinence, much like with constipation, we try to work on a schedule and a regimen, right? You want to drink your water, to eat your fiber, eat at the same times of day, use the squatty potty, get on a schedule. We try to work on timing voids to create a more predictable bowel schedule. And one of those things we do is to work on holding on. So sometimes I'll say, if you have a really strong urge to have a bowel movement, I want you to go to the bathroom and sit on the toilet like you were going to go, but you're going to try and hold it back, right? Just to work on more of the sphincter control. And again, the don'ts are, we don't want you to rush to the bathroom, still go, but don't run, don't hold too long, and don't sit on the toilet too long. And I have alluded to this quite a bit as far as other symptoms of constipation and fecal incontinence, but I did just want to bring these up again, that rarely a bowel issue is isolated. So we see a lot of, as you can see, there's a lot crammed into a small space. So it's really not uncommon to get urinary issues, pelvic pain, pelvic organ prolapse, hemorrhoids, anal fissures, other musculoskeletal pain, or sexual dysfunction as a result of bowel and bladder disorder, mostly bowel, but bowel and bladder disorders. So then, just to kind of review, the best bowel practice is drinking your water. And I know everyone here is 48 to 64, and that's very much an individual preference and range, but making sure you're getting enough water, making sure you're getting enough fiber, making sure you're active, making sure you're getting a stool under your feet, right? Getting into a routine can help promote your bowel predictability. And so when to seek treatment, and this is specific to medical treatment. I mean, if you're having a lot of pain, if it's really painful to pass stool, if you feel like you're constipated, if you're having symptoms that are going on longer than 3 months, if you're feeling like you're afraid to leave your house because you're afraid that you're, going to have an accident, or if you are reliant on Imodium to go out and meet your friends, or if you're starting to notice other issues like pelvic pain or urinary incontinence, those would generally be indications of treatment. And usually they're treatable, and the earlier that we can get in and work on them, generally the better. So what would pelvic floor therapy do to help? And it really depends on, where your issues lie, certainly, but we want to make sure that you have optimal muscular support of your pelvis. So we'd want to work on your glutes and your hips and your abdominal strength, to create pressure to pass stool, improve your sphincter strength, making sure that your pelvic floor isn't solely supporting your pelvis, right? Making sure that other muscles are helping. As I was saying, we work a lot on habits, fiber water, teaching the bowel massage, breathing strategies. We do other treatment. It's called biofeedback, where we work on the actual muscle synergy patterns for contracting and relaxing. So I use this a lot with people whose muscles aren't doing the right thing when they go to have a bowel movement. And so they have constipation because of that. We do a lot of hands-on work, right? We might work a lot in the abdominal wall. We might do internal work to the pelvic floor or external work to the pelvic floor, just to optimize the function of those muscles. So I would say the two most common things that I do with my patients are Kegels, and I do kind of extend Kegels to the anal sphincter as well, and then abdominal bracing. And so when it comes to Kegels, and I was a little hesitant putting them in here because most people actually do Kegels wrong, but in general, you want to think about lifting your pelvic floor up towards your head. And a lot of us think of trying to stop pee, but I actually prefer people think about sucking water in through a straw using your vagina. And you can also emphasize the anal sphincter by thinking about holding back gas. It's just when you're doing these activities that we don't want you to squeeze your tummy too tight. We don't want you to squeeze your butt, right? And a lot of the time when it comes to Kegels, especially in people who have more weakness, they're gonna, you might want to compensate with your butt or your hips, and that's not necessarily going to have the best effect on strengthening the pelvic muscles. And then there's the abdominal brace. And so that's where you think about gently pulling your belly button towards your spine and pulling your hip bones together in front. So it's not a full-on suck it in where you can hardly breathe. It's more of a gentle brace. I think I have. Oh, and then I included pictures. I think this one got cut off a little bit, but some of the first line of exercises that I give to patients are, if you're laying on your back, you're squeezing your knees together into a ball, or pushing your knees out into a stretchy band, lifting your butt up and down, or on the side here doing what's called a clamshell to get into your outer hips. A lot of these, by working these muscles, you'll get some activity in your pelvic floor, but it's really a good way just to get things moving and to get the pelvic floor muscles starting to activate. And so that can be really helpful when we then start to try and bias just a pelvic floor contraction or a Kegel or just an anal sphincter contraction. So that brings me to the end of my presentation. So I wanted to, take if you guys have any questions. Oops, turn this back to the arrow.
So if you do have questions for Betsy, you can unmute yourself and ask. You don't have to show your face like me. I just like to do that so she's not the only person on the screen, because sometimes it's not as comfortable when you're the only one looking at a whole bunch of names. Does anybody have any questions?
Or you can chat them.
Yes, or you can chat them if you don't want to ask per se. I have one.
Sure.
So I broke a rib this spring.
Oh.
And was told by my doctor to take a leave. And I took a leave about 8 days, and I didn't realize I was supposed to take it with food, and I got incredibly constipated. And it took me about 2 months to get my system back on track. And I'm using, I'm eating more just like sort of a bran cereal.
Okay.
And I am now taking probiotics, and I wanted to get your thoughts on all of that. For a while, I had to take Marilax because things just didn't want to come out at all. And my doctor had said, don't take that for more than 7 days in a row. And so anyway, I've kind of found myself back to my normal. And I guess what I'm wondering is, like, I'm happy with the brand and the probiotics, and I feel like if I just stick with that, I'm good. I want to know your thoughts on that.
Yeah, well, and I didn't talk about the gut flora, and so certainly taking more the non-steroidal medications slow you down and can impact kind of the gut bacteria, which we need to optimally digest our food. And so certainly a probiotic isn't something I always recommend. I try to leave that to the doctor, although I definitely believe in it. That certainly, depending on your diet or the medication that you're taking, if there's a pH change or something in the gut, you may see that you have like some strains going that are like flourishing and other strains that aren't. And there's specific conditions where there's something called SIBO. So it's called small intestinal bacterial overgrowth. So we'll see a lot of like bacteria that's going to create a lot more gas or indigestion. But so I tend to leave the probiotic more to the physicians, but I think that can be really helpful at just making sure that things are breaking down. Certainly if you're not getting that, then that can cause that's going to be more difficult. You might have harder stool as a result of that. So yes, I am a fan of a probiotic. I think the one that if I do recommend is just Align, because it's kind of just like gentle and everything, but I know there's like very specific ones depending on what you might need. And then the bran cereal, super high in fiber. So I didn't talk as much about fiber as I suppose I could have. So there's two kinds of fiber. There's soluble and insoluble. So the soluble fiber is going to dissolve, right? And that's actually what helps pull water into the gut. And then there is insoluble fiber, which is going to more like create the matrix for the stool to create it more solid. And so the bran that you're eating is a little bit more insoluble fiber, but it does have soluble. So you're probably getting a good mix of those to kind of bulk your stool back up. So if that works for you, that's great. Miralax can be some people's friend and then a lot of people's enemies. So there's not usually one dose that fits all. And it usually can wreak havoc. Although it is like our preferred, right? It's not a stimulant laxative. So I would say if you're not needing anything like that and you're making it, like you're probably like, that's a good routine. You're probably in a good place. And
so count myself lucky, it sounds like, that I was able to restore. Phew. Okay, good.
Yeah, absolutely.
Good, thank you.
So
anybody else have questions? I can't believe I'm the only one. You
it's
just
a
have to click
taboo
unmute.
subject. It's
It
not
is a
an
hard
easy
subject
thing to talk about.
Yeah, we should have called it TMI or something like that as well.
The next time I'll come up with a better title.
No, I think it was a great title. People knew what they were getting.
You're right, exactly. Well, I know you can go either way. It can be trickery or just a straight shot. So
oh, it looks like we might have someone came off mute. They might have a question. Kathy?
No, I'm just, in case I feel like commenting,
okay.
I unmuted myself.
Fair enough. All right, what were you going to say, Betsy?
I don't remember.
Oh, sorry.
That's okay. So, I remember. So I am down the road at Glenbrook. So, maybe you guys ever have questions.
Would you mind sharing your first screen again that has your information on it?
Yeah.
That might work.
Hold on.
And that way it's there just if people, want to reach out to you individually. And I'll tell you what, I will also, once you put it back up, I will then stop. Yeah.
It doesn't have here, let me update it. Hold on a minute.
Okay, great. And I'm going to stop recording.
Okay.
So